models within an electronic health record system. Today, I'll talk about a few lessons learned from an external validation of a suicide risk model. My name is Lydia Sequeira, and my co-authors are listed here on the slide. First, a bit of background and context. Suicide is a large public health concern, accounting for 800,000 deaths every year worldwide, and 4,000 deaths in Canada. Death by suicide happens across all sexes, genders, and ages, with certain populations and groups being at a higher risk. There are preventative interventions, including safety planning, restricting access to lethal means, pharmacotherapy, mental health treatment and care, amongst others. And these interventions are most effective when targeted at high-risk individuals. So unfortunately, research on suicidal risk factors that has been conducted over the past 50 years has uncovered factors with only limited predictive ability, and those that predict only a small amount of variance in suicidal behavior. With the advent of electronic health records, however, more representative and large samples and longitudinal data collection on a wide variety of predictor variables has allowed for more accurate predictive algorithms. Over the past 5 years, there's been an increase in the development of EHR-based predictive models, with models predicting suicidal behavior with relatively good precision. An area under the curve values as high as 0.9 in development and testing phases. Here are a few of the papers that I just mentioned. Oftentimes, such predictive algorithms primarily remain or are kept in the domain of research. These are not adopted within clinical practice due to patient safety concerns, clinical burden, and clinical interoperability of the predictors behind the suggested clinical decision. It's important, therefore, to understand how these algorithms may be spread across different countries and care settings. So over 2 decades ago, McGinn et al. Detailed 3 main steps in creating a clinical prediction rule, which have a broader application to predictive models for clinical use, such as suicide risk prediction models. These steps include derivation, which is identification of factors with predictive power, validation, which actually composes of 2 different types of validation. So narrow validation, which is applying the model in a similar clinical setting as its derivation, and broad validation, which is applying the model in multiple clinical settings. And then finally, the third stage or phase is impact analysis, studying how the model changes physician behavior or clinician behavior, improves outcomes, and reduces costs. So the objective for this paper or presentation is to measure the generalizability of a suicide risk prediction model meant for classifying short-term risk of suicide of mental health patients within a different context than which it was developed in. So our study focuses on that phase within validation that is referred to as a broad validation, essentially implementing an algorithm that was developed in another setting by assessing its performance in the new context. A little bit about the setting. So the suicide risk prediction model was developed by Cerner Math using the Cerner Health Facts Data Warehouse. This warehouse has been used for building risk predictive models for a variety of other clinical outcomes. This data warehouse uses de-identified electronic health record data collected over 20 years. And for deriving the suicide risk prediction model, electronic health records were extracted from over 119,409 inpatient psychiatry admissions across several different acute care institutions in the US. The broad validation was actually conducted at the Centre for Addiction and Mental Health in Toronto, Ontario, which is Canada's largest academic mental health hospital. This hospital uses a comprehensive EHR, which is Cerner-based, which was implemented 3 years prior to the beginning of the study. At the time of the study, the hospital had achieved stage 7 on the HIMSS electronic medical record adoption model, signifying that complete electronic health record, complete data warehousing for data analytics, and over 90% of physician documentation being through computerized provider order entry. The hospital's EHR, as I mentioned, is Cerner, and in an attempt to make or maximize feasibility of model implementation from a technical perspective, a suicide risk model chosen for implementation into the EHR was one derived by Cerner MAP. So with the help of a skilled technical team, this 18-variable model was implemented within the CAMH EHR in 2 different versions or phases. Here you can see an example of this dashboard, which was to display, within it, you can display categorized suicide risk ratings of low, moderate, or high in order to help clinicians with real-time decision-making, alerting them of high-risk patients while under their care, and to identify why someone was in the risk category that they were in. You were able to use the dashboard to find out exactly which predictor variables were contributing to their suicide risk score. So this model was implemented in 2 phases or versions, one in 2017 and the second in 2020. Before it was released to any clinicians, however, the next crucial step was to actually validate this and validate its performance against CAMH outcomes. So we mapped all possible predictors within our EHR at CAMH. And as you can note here from the initial 18-variable model, only 8 of these were able to be mapped. So version 1 of the model predicted death by suicide only 22% of the time and predicted suicide attempts only 20.5% of the time. When predicting non-outcomes, however, this is high. The model predicted the right outcome 81% of the time. In real life, the rate of outcomes of suicide, as you can see from the visual here, is not equal to that of non-suicide outcomes. It's much lower. And while this is a good thing for clinical care and humanity in general, it can make evaluating predicted models a little bit more difficult. Therefore, when looking at total accuracy, which is the proportion of classifications a model correctly predicts, version 1 of the model hit 73% for predicting death by suicide and 67% for predicting suicide attempts, largely because of the high specificity. Since the percentage of prediction for suicide outcomes was so low initially, we were then interested in seeing whether mapping additional predictor variables changed the performance. So after more data was collected for the outcome of suicide attempt, we remeasured how well the model did for this outcome. The model still demonstrated low sensitivity, predicting suicide attempts only 22.3% of the time. There were some practical challenges along the way that I'd like to highlight. First of all, of the 18 variables, we were only able to map 8 of them accurately within our EHR, 5 initially in version 1 and 8 by version 2. Reasons for this were both technical and institutional. That is, there wasn't a way to accurately map out many of these variables. The algorithm relied heavily on structured data found within admission and nursing assessments. Secondly, validation sizes were quite small. With regard to outcomes on suicide death, there was data on 44 individuals for measuring Model 1 performance and 458 suicide attempts by the time I measured version 2 performance. In order to collect data on the outcome of suicide attempt, a new field was actually implemented into the EHR for data collection during the course of the study, as you can see there. Finally, I was only able to validate the model on 38 45% of individuals who had died by suicide and 45.5% of individuals who had attempted suicide, because the remainder of the patients with these outcomes did not have any data for the predictors in the EHR prior to the outcome. Therefore, there were no model scores. Even with the 8 match prediction variables, only a fraction of those are captured frequently within the EHR. This graph here, gathered using a back-end analytics platform from the EHR, shows the utilization rates for 6 of the 8 variables used over a 1-year period. As you can see, some variables are captured very often, those that are required organizational practice. Most of these had 0 missing data rates. However, certain fields, such as the pessimism or hopelessness score and weight, were not captured as often. Finally, gathering data for the validation posed a challenge because of the many variables that were not being stored in the data warehouse at the time. Therefore, it was difficult to put in data requests as needed. There was a lot of manual work and chart audits involved to gather some of these outcomes, as well as the risk scores. Wanted to end by highlighting a few lessons learned. So the remainder of the 10 variables were present within free text documentation. So leveraging unstructured data using suicide risk detection algorithms would be required, or natural language processing algorithms would be needed. Second, retrospective validation using data from clinical data warehouses can be a first approach to validation prior to actually implementing the algorithm on the back end, since this can reduce the time and the effort required for validation and some of the technical challenges that come about. Third, using proprietary models posed a bit of a challenge in terms of transparency of the model, including finding out what the coefficients were, and therefore using previously published models to increase transparency, rigor, and validity is important. With that, I'd like to say thank you for listening, and please feel free to direct any questions that you may have to myself with my email there, or you can also reach me at Twitter. Thanks.